Jim, that's because we had to make sure we got whatever you have to say on recording.
So Jim Novelli, Discovery Behavioral Healthcare. So Lori said it all bummed, but I just got to make a statement, and I'm going to take this opportunity since there's a county commissioner present. I've been in mental health for over 27 years across 3 states, at the state level, the community level. And what you've accomplished in this county, Lori, is something I've not really witnessed very often. I think you've been a great resource to this community, great resource to behavioral health in general. And my concerns are that there's got to be a way to maintain you here somehow. This is just crazy because you've started something that I can guarantee will just fall apart probably. I can't think of anybody that's going to pick up these pieces and have the grace and ability that you have to go through these different groups and bring people together. When I see all the different people that have sit at the table and accomplished what you've done, it's just been really amazing. And I am just, I'm just flabbergasted that the county is going to let you walk away that easy. Maybe it's not the county, maybe it's public health, but whatever. But this is what happens when you get somebody of value comes into your community and does something for the community that is so successful, and then just lets them walk away with no plan, no idea what the next step is, and who's going to take over and what's the next grant going to look like. So, Laura, you've done a great job, and I'll miss you. Well, I know you're not really leaving, but I really appreciate everything you've done for the world of behavioral health and other things for the community. So.
Thank you. I should have made you go at the end. Thank you so much, Jim. And this has been a wonderful group to be working with to do this stuff, because you can't do it if you've got a bunch of people who won't work together. And this is definitely a group who's predisposed to working together. And I've so appreciated that. Lori Tinker.
I just feel like such a broken record. Insert tape, out comes the same thing from perspective of the hospital. Still highly stressed. Been certainly seeing an uptick of in the emergency room and also express care or urgent care, which is good in that people seem to be appropriately using urgent care, as opposed to calling EMS services or coming into the emergency room. Majority of people, I'll say, are appropriate using, so that's helpful. But we are attempting to uptick staffing in our urgent care. But the hospital is still very stressed with being understaffed and using a lot of travelers, keeping a very tight eye on finances. Very cognizant of the fragility of many small community hospitals in our state right now. We are in, I was cautioned not to say we're in a better state, but than they are, situation than they are, but we are, but we're doing better than most, which certainly does not mean we're doing okay, but we're doing better than most. Are probably vis-a-vis the folks around this table. We are still doing a lot of work with our undischargeable patients. As of yesterday, we have someone who's been with us for about 160 days and someone who's been with us for 130. Although last week we were successful in getting our guardianship patient placed in what everyone felt was not a placement of desperation, but a good placement that suited him, which, so having gone through so much with him, it felt good that he went to a good place, an appropriate place for him, and not just someplace other than us. But it's things are still tight. They certainly are. And ED would say that they are seeing an uptick of mental health. But so far is doing okay. Unfortunately, we go into a meeting with the emergency department after this meeting. And so if I get any further specifics, I will send them along via email to you all.
Great. Thank you, Lori, and I really appreciate you being here. I know it's
Oh.
summer. There's a lot of things you could be doing. Commissioner
Dr. Shaw.
Shaw, Commissioner Brotherton.
Hello, everyone. Greg Brotherton, Jefferson County Commissioner, and Jim said it all, but I don't have really any other update. Really sorry to see Lori going. This is the third time I've said goodbye. And to answer your question, Jim, I think we lost Lori the same way. What's the Hemingway line about how you lost all your money slowly and then quickly? It's sad to see her go. I wish we could have kept her, and I think it's incumbent on all of us, not just here at the Behavioral Health Consortium and CHIP as well, to remain unsiloed, which is, I think, Lori's greatest accomplishment in the county. So do appreciate all the work that you've given to the service you've given to Jefferson County, Lori.
Thank you. Dr. Caudill.
I am left a bit speechless. Kind of updates. I am just immensely sad because I feel like I have really grown from knowing you, and I would agree with Jim. Like, I work in other organizations where change is really, really, really hard, if not impossible. Where, because I'm a systems thinker and an agent of change, and I get pushed back and get called a bully occasionally, which is ridiculous, I think, in my opinion. I just want to do best for my patients and believe strongly that tradition is just peer pressure from the past. So I don't know. I do hope that you'll update us on who will fill your shoes or try. I'm not going to say replace you, because you're irreplaceable. And I hope that I can grow and learn as much from that person as I have from you. So your impact is huge. And I think beyond caring for individual patients and other clients, whatever we're choosing to call them, I think by creating a system that cares for them, you impact much greater, have much greater reach. So thanks for helping create that system.
Thank you so much. I wasn't expecting this today. Thank you. Denise Baker.
Thank you. Thanks, Jim, for your opinions and thoughts. I believe and am right on your same page exactly. So, and Dr. Carlbaum, your thoughts and despair are palpable, and I hope too that I get to help and support whoever takes this task on. Lori, I think you've done an amazing job. And so, but I want to let everybody know that this isn't the last time you get to say goodbye to Lori, Greg. We're going to have a little open house for Lori here at the Health Department on August 4th from 3:30 to 5:30. And I will, if you want to just put a check in your calendar now, these will be coming out as an invitation next week. You know, when you send out a wedding invitation, you send it 4 weeks in advance. So when you send out we're all like, don't know what to do with ourselves invitation to an open house, you send it out a couple weeks ahead. Okay, so updates from over here. We're worried about monkeypox, which we're hoping gets a new name, and we are concerned about the rising COVID levels as well, Lori. And so, you know, we're all saying it's best and it's wisest. If you are inside, you need to be wearing a mask if you're with people that you aren't always with. And maybe if you are, but you don't know where they've been, you need to be wearing a mask. So that's safest is wisest. And, you know, we're still struggling with this. So thank you.
Thank you, Denise. Anya.
Hi, I'm Anya. I think I know most of you, but I'm a social worker and a contractor with the Behavioral Health Consortium working on overdose education and prevention. I feel what everyone else is saying, and it's been a real honor, and I've learned so much from working with Lori, and really grateful to be connected with you all in this work. So I'm hopeful that we can still move forward in collaborative and good ways together. I have a little update. In June 26th, Dr. Carlbaum and I tabled at the Port Townsend Pride event, and it went really well. We distributed 68 boxes of naloxone in 4 hours, and I would estimate we had over 100 conversations with folks, probably more than that. Generally, it was really positive feedback. A lot of folks thanking us for being there. A lot of folks had heard of naloxone, but weren't super familiar with how it worked or what it was. Some folks had never heard of naloxone and were really excited to learn about it and to add it to their first aid kit. The only pushback really was folks saying, oh, I don't think I need that. I don't hang out with people like that. And Dr. Carlbaum was really skilled in challenging that misperception of who uses opioids or who might be able to respond to an overdose. So really grateful for his time and for our awesome community reception of that distribution. And I've got a couple more distributions coming up in the next few months. And I want to also reiterate that if folks have other opportunities where you think it might make sense for me to come and set up a table and do naloxone distribution, to please reach out to me. I've got kits that were sent to me from Sean Himmerly at the Department of Health. So I'm super excited to be doing that work and want to collaborate with you all to show up in places where it seems like it makes sense.
Thank you, Anya. I think we got a great thing in Anya. I'm so pleased with how this ramping up of our engagement is going with Anya, sort of taking the point on that.
Can I
Gabbie.
ask a question and
Oh.
clarify something for the record? I didn't do that much. I just supported Anya and watched her and learned her strategies to interact in amazingly non-judgmental ways with all sorts of humans, even some people that I think were pretty reluctant. So I learned a ton. It was awesome.
Thank you.
And together, you guys were an awesome team.
And Anya, congratulations on your, I believe, scholarship award that I might have seen in the newspaper. I still hope you might have time in your life to consider if you might be a good person to fill Lori's role.
Thank you.
I think that's a great idea. Gabbie.
I think that's a horrible idea because I don't want you to leave, Lori. I don't know that anyone can fill your shoes. I was going to be all happy today, and then Jim made me cry, so I had to go fix my face. Just to echo what everybody said, Lori, a lot of us go to the same meetings over and over with the same people, and the same people are at different meetings, and I think yours are the ones that seem to get things done. And I don't know that anybody can fill your role. Like I said, I am grateful to have worked beside you for the last several years. We've been an inspiration, and when I grow up, I'm going to be like you. Someday.
Thank you.
Yeah.
So did you have any updates, Gabbie? We can kind of, I'm looking, we've all sort of talked. Let me just check in with Dr. Carlbaum and see if he had anything update-wise that you'd like to share with the group. Otherwise, we'll roll into.
I think that's you secretly trying to tell me that I should be sharing something with the group, but I can't remember what it is.
No, that's not me secretly saying anything.
Okay.
What I think we can do is go ahead and start with the discussion around the new mobile unit that Gabbie has news to share on. And then there's sort of a discussion about how that starts to integrate with the county that I think is I'm sorry, with the South County area, which I think is the crux of what we want to talk through today. Do you all have a slide packet, or should I show the slide? Get over. And then Gabbie, I'm just going to kind of turn it over to you to sort of say what all's going on with the unit what the exciting news is.
All right, so our mobile unit is officially licensed by Department of Health now to provide services. Our remodel is done. We did not get it wrapped because everybody doing wrapping is booked way out. So we just want to get it going. So we actually redid the outside ourselves until we can get it wrapped. So don't judge me. Our mobile unit was created with the idea of bringing services to the high barrier isolated areas in our county. And our hope is that we're able to bring those services to both Quilcene and Brennan and beyond. I know that this meeting in particular is about those areas. And our mobile unit, we are able to provide all of the same services that we're able to provide in our office. So SUD assessments, relapse prevention, outpatient services, intensive outpatient services. There is a bathroom. It's a 29-foot RV, so it's quite large. And so we're able to do urinalysis. We'll be able to provide case management services as well, peer support services. And we also have free naloxone available
Gabbie, I
on our
wonder,
unit.
I can see that Greg has a question. I just want to make sure he gets it in when we're in the right realm of the discussion.
You know, question/comment, and I'm sorry, I wasn't trying to interrupt, but I do have to leave at 1:30 for another meeting as I chatted. But I'm just wondering, Gabbie, if you reached out to the food banks. I work with them a lot, and I've had a couple conversations with the folks that run the Brennan Food Bank, which is Tuesday mornings, and the Quilcene Food Bank, which is Wednesday mornings. And I think both of those locations would be a great to kind of make your presence known, you know, a 3-hour segment where, you know, a lot of the same population's going to be there. So they're really excited about the option. If I can help connect you, I'd be happy to, or if you already have those connections, I think you should reach out.
That would be amazing. So later on in my presentation, I was going to ask who should we be talking to? So that's great. Parking, we definitely need somewhere to park the unit for 3-hour blocks. That way we can provide our group sessions and have time for assessments or individual sessions, whatever that looks like for the day. We need, do you want me to go into this right now? So we need somewhere to park in both Quilcene and Brennan, preferably in regularly scheduled 3-hour blocks. So our hope is to be out there, like, you know, whatever that looks like. So if we're out there Monday, Tuesday, Thursday, Friday, or Monday, Tuesday, Wednesday, Thursday from 9 to noon, and then go to Brennan from 1 to 4 or something. Just having somewhere that we're definitely going to be on regularly scheduled days so people know where we are and how to access us. We need somewhere to hang our flyers out there. So if you know of anywhere, we'll definitely be going to the food banks, the fire department, the stores out there. Our plan is to right now go out there, and I'll go over the timeline a little bit in a minute. What else do we need? Ongoing collaboration with our South County community partners. So Greg, I appreciate that. I have a meeting with the Quilcene Fire Department tomorrow. I've met with Art Frank, who's one of the fire commissioners out there, which I actually didn't realize when I was meeting with him, but found that out later. And then just to know who else we should be talking to down there, if you have anybody. And then I have this email that I'm going to send out to all of you guys that just kind of outlines everything that I'm talking about today. And I'm available to speak with anybody about this opportunity, what it looks like for them seeking services, what it looks like for people to have us parked in their parking lot, all of that stuff. Our timeline, our goal over the next 2 weeks is to establish a fixed schedule of operating sites so we can be reliable for people that are seeking services out there. From August 1st to August 12th. We will be bringing the mobile unit to the designated parking locations and doing walk-in services during that time. Anybody can walk in, and if they want to see what we're about there, then we'll be doing that. If they want to seek services, we'll have that open for them. And then August 15th is when we want to start providing services regularly at our scheduled locations. And then for partnerships, we've partnered with Olympic Personal Health Services. They'll be providing mat inductions and maintenance via telehealth, similar to what they already do in the community for our outreach program. So telehealth appointments are available on the unit. If somebody needs help filling out applications, that's available as well. We've partnered with OLICAP, who will be continuing to provide housing resources for people. And again, if somebody needs help filling out applications, our case manager is able to do that. And much like our jail program, they're able to meet with people via telehealth. And then we've partnered with public health to receive harm reduction supplies, so wound care stuff. And we've been talking about doing that. Not sure when our next meeting is about that, Lori, but off the top of my head, I don't know. So that we've done that. And then Gateway to Freedom will be providing toiletries, clothing, tents, sleeping bags, limited transportation. We'll have the same access to a clothing closet that we have right now at our office. So there's our goal is just to bring everything that we offer currently out into the community where people can access it a little bit easier out there.
Thanks, Gabbie. Chief McCurran.
Real quick for Chief, before Commissioner leaves, Gabbie, we're happy to report to you, you have a place to stay. And last night we endorsed that you'll be housed at our fire station. We have bathroom facilities. We got places to store the stuff that you're getting from OLICAP right next to we've got an extra bay station here. So you are certainly welcome. And I'm happy to report to you folks that they will be here at Coolstein Fire on Herbert Street.
Yay. That's so exciting. Thank you.
You bet. I look forward to talking to you tomorrow to firm this up and get dates and times and all that. I wanted the commissioner here before he departed for his next meeting that we're good to go. And you're right around the corner from the food bank. And actually, soon you'll be on the same street as the food bank. So I think that you're in the right location at the right place, including power and everything else that's needed. And the big important factor is that we'll hook up to the internet so that as you're doing computer stuff, you'll have live access to an internet and you can continue doing your work that way.
Perfect.
That's huge. Thank you so much.
It is. Yes, that's exciting. Thank you.
Well, you had a meeting with a guy who you didn't know was a commissioner, and it just so happens he's the chairman of my board, and he was very adequate and very eloquent last evening at our meeting, and so I already knew about the program, was able to talk to the rest of the board, so they were super excited about it. So we're looking forward to get things going.
Excellent. Excellent. As we were brainstorming sort of the realm of things that we might be thinking about, that we could use what Gabbie is doing for. One of the things I've been thinking is that there is a need for us to have a better understanding of what's happening on the ground in terms of what drugs are being used, how much fentanyl has actually made its way into this landscape. And I wondered if we might consider a few questions, and I put up a few as samples here that I think I would find interesting, but is there anything else that anyone else from this table thinks that we should be, as long as we're having contact, that maybe we have an opportunity to get some insight that we don't have right now?
I've also heard about from folks who are in active use, the rise of fentanyl powder. So that might be a question.
Okay, so for the person who doesn't know much, how is the powder, aren't pills always mashed up into pieces?
Yeah, there's pressed pills, but people are also distributing just like fentanyl powder, powdered fentanyl. So I think that might have a higher, I don't know, it might have a higher risk of overdose because it's not, dosed in a pill and because it's fentanyl that's not made in a real pharmacological space, it's not distributed evenly through the powder. So I've heard from folks who are in active fentanyl use like a fear of the powder. But if you're dependent on fentanyl and that's what's available, that might be what you use.
Mhm. Holly.
I have a friend that just had 2 coworkers 2 weekends ago at a party that they were given laced cocaine, and the cocaine was laced with the fentanyl, and one of her friends did pass away. The other one lived, but has pretty significant health drawbacks from that, and she's still over in the hospital. But on my only other piece was the phrasing of the questions. Is when you frame it like asking pointed questions, like are you using fentanyl pills, tends to get better responses if you're asking if you or do you or does someone you know. Always put in that option where you might be talking about somebody else that you know instead of like only responding on behalf of yourself. You may get some more responses.
Thank you
think
so much.
these are questions that are already kind of on the substance use disorder assessments, not directly phrased like this, but I mean, we have to do a use history and just talk about, okay, well, tell me about what you're using and how much are you using? How do you use your drugs? Are you using every day, once a week, once a month? And we already look at all of this, and I have data surrounding this. I'm sure Jim does as well, because this is stuff that is actually on the assessment and stuff we have to report on.
So my question then is, can we have some regular place where we share what we're learning, take a look at what we're getting in terms of insight and share it amongst ourselves? I think.
Are you wanting specifically South County data now?
Only because that's the place where I know that somebody's going to be talking directly to people who probably aren't coming into public health. They aren't on our radar or in our intersection pathway most any place else. So you're gonna have access to, I think, some bubbles of information that we haven't gotten into before.
I'm happy to keep the data that we already collect, because like I said, it is this. I don't know about have you noticed if friends who had been injecting opiates? I don't know about that one, but I can tell you just in the last 6 months, I maybe have had one person that identifies their drug of choice as heroin now. The drug of choice is primarily fentanyl.
And do you know if it's mostly injection or mostly?
People smoke it. It doesn't dissolve correctly to be injected if it's the counterfeit stuff. If somebody can get a hold of like a fentanyl patch, there's a way to like get it out of the patch and inject it then, but the way the pills are manufactured, they don't dissolve.
Okay. That was what that question was moving toward, is the reason. Do we have less people coming to syringe exchange because they're not actually using syringes? And then that eliminates our chance to interact with them. And so if they are smoking, then whatever we come up with in terms of a safe smoking or wound care or that sort of thing, stuff that we're handing out, that might be another way to make sure that we're interacting with more people than we are currently at the syringe exchange.
There's still, the people that I have that are now smoking versus 6 months ago shooting up heroin, they're still shooting up meth because IV use is still the main route of administration that they desire. But until whoever decides to come up with a way that they can smoke whatever, or they can shoot whatever fentanyl pills are doing, it's not happening.
Any other thoughts on that before I move to the next thing that I've been thinking about? So we know that there is this space between Brennan and a pharmacy, and I know that Gabbie has said that she would drive folks back and forth, but if there was some way that we come up with that was creative and effective, so that we had the prescriptions, you know, I don't know if we could get them in with the hospital clinic. I don't know if we could do them at the school-based health clinic. This isn't anything that we've really just explored before, but I'm wondering if there is a way we could make use of one of those clinic facilities as a place where a prescription could be brought to, so that we have access. And then if it's not that, if that's not the answer, I'm open to other ideas, but I think it might be, particularly if gas keeps getting more and more expensive, it might be a tough call to get people, especially if you really want to catch people when they're ready to take this step, to go through the process of getting up to Port Townsend or getting their prescription filled.
I don't have an answer.
I could definitely ask regarding the school-based health clinics, or the space that we have in the back of where the Jefferson Healthcare has a clinic. That clinic doesn't, that Jefferson Healthcare clinic, as far as I know, doesn't have any real stable hours right now. And our clinic behind that doesn't have really stable hours right now either. But you know, I could see the school not wanting to have
Right.
those prescriptions there.
I mean,
But we have space, don't we have space that's not on the school, that they're down there in the summer?
Well,
Behind,
that's our one behind the
I think that's where I was thinking, not at the school.
yeah, that's our one behind the post office. And I can definitely ask, but Jim, it sounds like what's gonna say something.
Sorry.
well, I mean, Suboxone's still a controlled substance, and you got to be careful with it, where you store it and security wise. I mean, I hear what you're saying. I don't think any school's going to want it in a closet. You know, we any medications we have. In fact, we don't even, when we don't have Suboxone on site, we have to get it from the pharmacy. We give them a prescription. So it's not something that you really want to transport, and you have to be cautious with. So as there are federal regulations requiring the handling of it. So
That's true of the medications that we have for the school-based health clinics. They just take those the days they use them.
Do you guys keep medication on hand, Jim, or do you just write the prescriptions and
for the
they-
Suboxone, we just write the prescription. Right. And we do, Genoa Healthcare does our is our pharmacy that we utilize the most, and their behavioral health pharmacy. And so they send us the meds at the beginning of the week, and we distribute them as needed, as necessary to the people. So
Thank you.
And do they bill Apple Health then?
yes, so
Dr. Caudill?
Yeah, I'm just wondering, with gas prices and transportation challenges, I'm wondering if there's other ways to get buprenorphine or Suboxone to people. And I had stumbled across, I get all sorts of medical journal emails of table of contents, and one grabbed my eye about depot buprenorphine. I guess it's an injection that lasts like a week or a month. I don't know much about it. I don't use it in my practice. And I wonder, and this was a survey of people who were randomized to either pills or depot. And in general, people had a higher quality of life and had less relapses and less overdoses after stopping the oral and reusing fentanyl after their receptors had been reset. And I don't know if you're infrequently touching all these different communities, Gabbie, if that's an option to have it in your vehicle and have someone administer it. I don't know if that's a better option. So
It's expensive.
I see.
Go ahead, Jim.
But aren't there rules about who can do injections? I know in our facility, only a nurse or an MA can provide those injections. So you have to have that level. You have to have certain certification. So that would be my concern is, you can't just have somebody like me or Gabbie doing an injection, even if you were trained.
But you can have
And
somebody at a clinic do it. Is that true? I mean, a registered somebody.
so if we were gonna do that, OPHS could go out with us in person 1 day a week and do all the injections. And I actually had this conversation with them yesterday, and it's very expensive. And so you have to get prior auth from Medicaid still in order to use it. And so just like a lot of people that want Suboxone need to get started on it. Like you have a very small window where somebody's like, okay, I should stop using fentanyl, or I need to do something about this. And so they go and get Suboxone, and the follow-up after that is somewhat difficult. And so if you have that small window and then you're like, you know what, you need to wait a few days so we can get prior auth, and by then somebody might not even want it anymore. So
Got
you've
it.
done all this work for nothing.
Got it.
Is
Thanks.
is it even indicated as a first route? I thought you had to start another route first before you started the injections.
You do. And again, with the prior auth, you have to explain why you're trying to get somebody on the injection rather than.
The insurance companies do not make anything easy, for sure.
Well, I'll
I
tell you what I do like about the idea of, it sounds like it's an extended release kind of a thing. So once you start, you're in the game for a solid period of time. That sounds great. And I also think it sounds, we might avoid having a secondary Suboxone market that we inadvertently set up. So I understand. So what I'm hearing is it's complicated. We don't have all the answers yet. There are some pros and there are some difficulties in actually administering it that would need to be worked through. So I think we just keep that in mind going forward. Any other thoughts on that before I move to quick overview of vending machine? Okay, Jim, what do you know about the vending machine?
I don't know a whole lot. Things have been pretty hectic, so I have not really done much on that, on the vending machines up to now. We've had a lot of different projects on our lap, so that's kind of fallen down off on the wayside considering all the other things that have been up on top. But I do know that probably, price of one. I mean, there's just a question. We got same questions are still there. Where to purchase one? We know we can put it in the community center. And the question is, I understand that Manly is willing to keep it stocked. So the next question is, obviously, monitoring it and getting the supply on a regular basis to monitor and put it in. Machine itself, probably we can get one within, I don't think it'd be much more than $5,000-$6,000 from what I understand. And, make it secure in a secure setting so it doesn't get broken into every night. That's the next thing that we'd have to be concerned about. But I think it's back on my radar again. I just had a few other projects, like putting in a SAMHSA grant, which took a lot of time. So anyhow, that moving forward, I think it's well worth going and pursuing and keeping with it. And we just have to search for a vendor that sells those machines and get the right price and find the funding.
So I know this particular project, the vending machine, I'm leaving, it's not done yet, but I think it's a really important thing that you guys see if you can accomplish through this grant. I know that it's going to require some collaboration, I'm imagining, between DBH and JCPH, because there's going to be some technological, there's getting the machine in, and then there's maintaining and keeping whatever data it is that you gather from whatever technological interface there is. So I know it's going to be a process, and I really hope that as this transitions to the next person, that does end up happening by the end of the grant. And because we've done all of this work to get to know each other, I don't think 2 years ago we could have just stepped into a table and said, yeah, let's put a vending machine down there. That we've got everybody agreed to it, I think is an awesome thing. Is there anything else before I give you my last little tip and maybe even let you guys go early? All right, I just want to recommend this podcast, Hooked. Even if you didn't listen to the whole thing, the first 2 episodes of it, give a really nice storyfied overview of what's been happening with the opioid pharmaceutical side of things, and takes it down to a personal life. And it's a personal life of somebody who lives in the Seattle area, you know, worked at Boeing. It's very relatable. And I'm impressed with how they drew the line in terms of what was happening at the pharmaceutical level, with how that impacted these various decisions that this one individual made, and, you know, the course that his life took. So you don't have to listen to the whole thing, but I think it's a great overview at the outset of it, if you're wanting to get the landscape in an easy to absorb way. And I think that's all I've got.
Can I ask one question?
Yeah.
I think the story that Holly shared about the folks who are overdosed from fentanyl from cocaine use kind of highlights the need or the use that we could have for fentanyl test strips. I know that we know that fentanyl is in all opioids, but fentanyl is showing up in drugs like cocaine, ecstasy, MDMA, things like that, that those folks probably don't have naloxone on hand. As like opioid users, the norm now is like you have naloxone on hand. So I'm not sure, I know that we talked about fentanyl test strips in the past, and I'm not sure where that conversation still lies, but I would like to bring it up again. I think it's something that I would be open to having and tabling booths to talk to folks who say, oh, I don't use opioids. And, you know, well, if you use any other party drug, or even if you don't have a drug chemical dependency, it's I think an opening talking point, and can be life-saving. If you think you're using cocaine and you test it and you see there's fentanyl in it, then you will be way less likely to overdose.
Mm-hmm. That's really a valuable insight. Other folks? Okay.
I would agree. I think I would agree with Anya. I guess I'm behind in recognizing how pervasive fentanyl is in every single substance that people are distributing to others to use. So if it could reduce a death, you know, we've seen, gosh, Chief, like 4 cardiac arrests in the past 3 months of youngish people who have died. It's probably related to opioids and are unwitnessed because they're alone, or difficult access circumstances, and because of that delay, you know, we've had one great success in closing, but since then we've had multiple deaths that I'm sure were related to fentanyl. So anything we can do to reduce that would be great.
And so, Anya, I think that our conversation had been with Ocean and Lisa, et cetera, in the syringe exchange program over here at the health department. And I'm super willing to, you know, start that conversation up again, because I know that they had said initially the fentanyl, the people coming to SSP weren't interested in taking fentanyl strips anymore. They said fentanyl's in everything, and, you know, we're just not interested in taking the strips. And so the strips weren't being distributed. And so we reduced, you know, our supply. But I'm totally open to opening that conversation again.
I think that'd be great. And to have the strips available when you're tabling at events, Anya, I think makes sense, because you're right, you're talking to a range of demographics when you're at those events. Okay.
I had one quick question for Anya, if we have time. Anya, are you going to be tabling at the Thing Festival?
I am, yeah.
Excellent. How much are you bringing?
Depending on, right now I have 237 boxes. So depending on how much I distribute before then, yeah.
Got it. That may not be it. Just saying. Are there like 5,000 people or 10,000 people coming?
Mm-hmm.
Maybe we want to, I'm wondering if we should put in another order, Anya. Can you do that through Sean?
I can ask. Sean Himmerly was the person who asked if I could table at ThinkFest, and I'd already been in contact with ThinkFest. I think he's going, so I think he was excited that I wanted to table there, and so I could ask for more. Yeah.
Cool.
Depending on the date, I might be willing to come to some of it if I'm allowed to wear earplugs.
Great. And I've tabled there before for another organization, and the tabling section is outside of the ticketed event. And it's not super loud, and not everybody goes by there. So yeah.
So I could even visit you at that table, Anya.
Yes.
Which event are you discussing, Doc? 'Cause I guess I'm a little lost at that one.
It's
I haven't-
it's a music venue at Fort Ward, which is
Fort
which is
Worden.
on Cambridge. Fort Worden, that is in early August, that has a lot of world-renowned bands coming and a lot of humans coming to see all those bands.
Yes, it's August, the weekend of August 26th.
That'd be just great. Just so you know, there's another event, probably the same weekend. We have weekends every weekend in the month of August at the MUND group. And the Departure Fest starts the first weekend in August. That will be fairly large, not as large as what you're describing, Doc, but I think we're definitely talking in the tunes of 500 to 600. And they're actually going to stay the entire weekend. So we get them Friday, Saturday, and Sunday for the entire weekend. And it's every weekend in the month of August. There's something else going on, from Moonfest to the Herbal Festival, and it's going to start with the Departure Fest on the first one there. So I don't know if you've reached out to those folks or not.
I haven't reached out to all of them, but I would be interested in that. So thanks for that insight.
Okay. Going once, going twice. Everybody have a great afternoon. Thanks so much for working with me. Bye-bye.